So let me jump right in. As mentioned, I'm going to be talking about this topic of fetal embolization of vein of Galen malformation. And much less fetal use in here is going to be off-label. I wanted to start with a brief recapitulation of cerebrovascular development embryologically. And these figures are taken from Charles Raybo's beautiful review of this topic. So at the beginning, of course, there's an open neural tube with the tube floating in amniotic fluid, and all oxygenation takes place by diffusion. And eventually, endothelial network starts to form on the surface of the neural tube, and it coalesces into something called the meninx primitiva, which surrounds the neural tube. And eventually, there's an invagination into each hemisphere of a bit of that meninx primitiva into the ventricles. And that's what becomes the choroid plexus. So a highly vascularized meninx eventually becomes the choroid plexus. And early on, the vascular supply to the brain is organized around the choroid plexus. So start to get the choroidal vessels, and there you see they're in the range of the choroid plexus. And the earliest large veins that organize also drain the region of the choroid. Normally arteriovenous loops that form in this area with just capillaries separating the choroidal arteries from the venous drainage. Venous loops dissipate. And what is supposed to happen is the anterior aspect of the median prosencephalic vein should become plexiform and eventually involute, and the back end of it is what will become the true vein of Galen. So you can see that's what's happening on this half of the figure here. This is the front, the anterior part of the prosencephalic vein, which has become plexiform. It will go on to involute. This becomes the vein of Galen. No more arteriovenous communication. But when there's a vein of Galen malformation, that process never happens. So now we're looking at a sagittal view. The prosencephalic vein never involutes. It never becomes plexiform. The arteriovenous loops remain intact, and you essentially have an arteriovenous fistula, which can be simple or very complex with arterialized flow into the prosencephalic vein that then either drains through a classic straight sinus or through various possible Falcine sinuses that are retained from embryological life. I want to mention very parenthetically, there's been lots of very interesting research. It's clear that there's a complex genetic network underlying all of this. Lots of genes have been identified as players in this, not just vein of Galen malformation, but lots of other cerebrovascular entities. And specifically with regard to vein of Galen malformation, Chris Cayley, who's a neurosurgeon at Yale, has been doing a really beautiful project on whole exome sequencing, collecting genetic material from infants and their parents from around the world. We're part of this group, and recently published this paper in Neuron showing, based on whole exome sequencing, individualized mutations for given patients and starting to correlate actual genetic mutations with phenotypic expression. And clearly, mutations in the ephrin pathway and the chromatin pathway, and then previously identified mutations in other pathways are very important and will become more important down the road. But let's step away from that. That's not going to be the focus of this talk, and just focus on how are we doing in terms of clinical management of vein of Galen malformations. So the clinical manifestations have been known for a long time. Of course, this is a classic paper from back in 1964. And already you can see almost all the manifestations. So an enlarged heart and cardiac failure is often the early manifestation in the neonatal stage. Macrocrania and ventriculomegaly is clear, with major impact on the cerebral parenchyma. And this was a review paper that was published in the late 1980s that was sort of the tail end of the era of neurosurgical management of vein of Galen malformation. And unfortunately, it's not a condition that responds well to surgical management. So very high mortality and morbidity rates. You can see in the neonatal patients, there was over a 90% mortality. It really used to be a terrible diagnosis with very grim prognosis. And that was upended in the late 80s by the work of Pierre Legenius and his colleagues in Paris, who developed the techniques for embolization of these malformations. This was a review paper he wrote in 2006, reflecting his 20-year experience, actually just before his unfortunate death. And let me just show you how that goes. So here's an angiogram from an infant with a vein of Galen malformation. As I mentioned, the morphology can be quite different. In this case, it's almost nidal like an AVM. And here you can see the median prosencephalic vein with the nidal vessels in the frontal view and the lateral view. And depending on what the morphology is, you recapitulate that with your embolic agent, in this case, glue or onyx. So here's the microcatheter injection. You can see only those nidal vessels are being injected, no peel supply at all. And you can see the glue cast in this case in frontal and lateral view. And on the follow-up angiogram, there's no more filling of the vein of Galen malformation with arteriovenous flow. It does fill passively just because it's still, the prosencephalic vein is still open and connected to the venous system. But the result of that, the net upshot, is that here's the initial sagittal MRI, and the median prosencephalic vein will involute if you manage to close off all of the flow. Here's another case showing the diagnosis from fetal life, and then the neonatal scan. This is a very different kind of morphology, required a different kind of embolization, but once again, not embolizing the prosencephalic vein itself, just the arterial inflow and maybe the early part of the vein results in complete involution of that vein eventually, and a great outcome for many patients. There have been several review papers recently describing how well we do with embolization. This one was from several years back, and it organizes the outcomes by decades, starting from the bottom and going up. So here are the early papers in the 1980s. In red, I put the percentage of bad outcomes. So you can see back in the 80s, about half the embolized patients did badly. That went down to about a third, and then less than a third in the 2000s. So for many patients, for most patients who are being embolized, we can do quite well. The problem is that the selection criteria for who we decide to embolize are fairly rigid, and Pierre Legenius developed a system called the Bicêtre scale, which essentially weighs how sick the newborn is from the vein of Galen malformation. And they can have neurologic manifestations. They almost always have cardiac manifestations when they're sick. They have very aggressive pulmonary hypertension. They can develop renal and hepatic issues because of poor flow down the descending aorta, because so much of the blood is being shunted up to the head. So there's a wide range of severity. And it turns out that if you use these Bicêtre criteria, you exclude many, many newborns from treatment in the first place. So those numbers that we see in the papers that are being published by neurointerventional neurosurgical groups about success rates for vein of Galen malformation focus on the embolized cohort. But there is literature out there on the broader view from the perspective of the pregnant mom. What is the chance that that fetus, without any selection at birth, will do well? And it turns out not nearly as good as you would think from the literature that's been published in the neurointerventional world. So a recent review looked at all published prenatally diagnosed cases, and you find very high morbidity and mortality with really only about a 1/3 chance of that fetus surviving the neonatal period and then to childhood and adulthood without significant neurologic impairment. Similar studies done in Paris and Genoa found, again, a similar number from the perspective of the diagnosed fetus. Only about a third of them will actually go on to survive infancy without significant neurologic impairment. This has really been shown beautifully by two landmark papers that were published by the Great Ormond Street Hospital Group in the last few years. They have a huge practice, and they have the advantage of a completely nationalized practice where essentially every case in the UK is sent to them for consideration for treatment. What they found is that about 2/3 of all the newborns born with this condition present with the acute presentation with acute heart failure at birth. And they're a very experienced group, extremely skilled, and even in their hands, in that 2/3 fraction of all patients who present as sick neonates, there's about a 40% mortality. And of the 60% who survive as a result of the embolization, about half of them will have severe neurocognitive impairment. So if you put those numbers together, there's less than a 1/3 likelihood in this cohort of severe presenters of survival to adulthood without significant neurologic injury. If you look at the other third of patients who don't present as neonates, but instead make it through the neonatal period and they come back as infants for elective embolization, the mortality rate is much lower. So they have a 90% survival. About 30% have a poor neurologic outcome. So the numbers are really not as good as we would like to think. Let me just show you some cases. This was a 1-day-old born in Miami who was airlifted to us for potential embolization. Clearly, there are some parenchymal injuries already, even at birth, but most of the brain is still intact. By the time we got them to us, we repeated the MRI scan before embolization. This is day 9. You can see widespread bihemispheric injuries in the hemisphere. There's really nothing that we could possibly do to help this child at this point. Here's another case, a 2-week-old with a vein of Galen malformation, already extensive bihemispheric parenchymal injuries. Another case, a 1-day-old, there's really no brain parenchyma to speak of in either hemisphere. Another case, a 3-day-old, the entire left hemisphere is already gliotic, essentially. So obviously, there's nothing we can offer to these many, many cases using current standard of care treatment. So if we step back and ask ourselves honestly, how are we really doing with this treatment? The answer is that from the perspective of the pregnant mother, the chances of a tragic outcome still outweigh the chances of all other outcomes. And there's clearly a need for innovation in this area. So that leads to the topic of which is the possibility of fetal interventions. So the first order of business would be to identify an appropriate cohort, and you can split all the fetuses with vein of Galen malformation into 3. At the bottom, we'll start with the severe fetal presentation. Those are the rare cases where you already see diffuse brain injuries in utero. That turns out to be quite rare, but that would not be an appropriate cohort for fetal intervention. They're already beyond salvage. Those kids, when they're born, typically do not even survive with standard of care neonatal embolization. And if they do survive, they're tremendously impaired with basically unremitting seizures and no significant development to speak of. On the other hand, at the top of the slide, the infant treatment cohort, that's about 1/3 of all cases who make it through the neonatal period to elective treatment as infants. As I said, they have a very low mortality of about 10%. There is a 30% chance of having a poor outcome in the survivors, but still that's not severe enough for a fetal intervention as a novel project. So really the group we want to focus on is this middle group, the neonatal at-risk group. That's about the 2/3 of all fetuses with vein of Galen malformation who will present severely as neonates with overwhelming heart failure. They're the ones who have the near 50% mortality, and in the survivors, they have a high rate of severe neurocognitive outcome as well. So that's the appropriate cohorts. Identify those patients in utero so that we know that we could target fetal therapy to them. And we undertook a project to do this in the last few years. We did a systematic analysis, first of all of our neonatal scans that we always get a day 1 of life scan. And then we tried to correlate that with clinical presentation in the NICU. And then when we found some variables that seemed to correlate well, we went back and looked at our fetal scans, and we asked the question, is there any variable that really predicts well how this fetus did clinically? And it turns out there is. I'll show you on the next slide. But if you measure specifically the outflow from the prosencephalic varix at its shortest point, and you measure the width of that, so it's either the Falcine sinus or the straight sinus, at that shortest point, you can predict very robustly how that fetus will present clinically. And here you can just see what the numbers look like. Here's the diameter of that spot. The width of that spot. As it goes up, the probability that that fetus will present as a severe neonate goes up very dramatically until when you get to about looking at about a 90% probability with very high 95% confidence interval. This is what it actually looks like on the scan. In almost every case on the sagittal view, you will find the shortest point in the Falcine sinus. And if you take that point and measure the width of the sinus at that point, that is the predictor of the fetal outcome. It sort of makes sense intuitively because the Falcine sinus is firmly tacked down at the top and the bottom, but the width is able to expand with flow. So the wider the sinus is here, that's a very good proxy for the degree of flow. And the degree of flow is a very likely contributor to the overall systemic health of the baby and whether they have pulmonary failure or not. So armed with that, the question was, what can we do in terms of a fetal intervention? And here, I was really inspired by our program in fetal cardiac interventions, which we've had a very robust program for over a decade now in the hospital. And I'll just show you some slides showing what it looks like. So they started out doing fetal interventions for congenital aortic valve stenosis and doing balloon angioplasty to prevent hypoplastic left heart syndrome, which is fatal. And the way they do that is they essentially do a fetal balloon dilatation in utero. So it's done with mom getting a spinal anesthesia. The fetus is then positioned properly for the intervention. And the first step is there's a fetal anesthesiologist who gives this. You can see the injection into the muscle of the fetus, into the buttock. You can actually see the jet of anesthetic and paralytic going in once the baby is in position. This is all done under ultrasound, obviously. And then here you see the trocar going transsternally into the left ventricle. Here you see the guide wire passing through the aortic valve into the aorta for balloon dilatation. They've done several hundreds of cases now. Developed, undertaking the approach vein of malformation in a similar way. So in this case, the fetus would be the back of the head towards the mom anterior, facing the front of the mom. The MFM would direct a needle under ultrasound through the posterior fontanelle into the torcular, which is always massively enlarged in these babies. So that to the Falcine sinus and then into the prosencephalic varix, where it will be coiled. The goal will not be to coil it to closure, but just to significantly coil it with a packing volume that should diminish the overall flow through the malformation. And the goal much higher survival rate and lower nerve outcome. Now, as I showed you on the images before, but that's not to say that coiling the varix is never done. And I use it as a sort of safety pop-off technique when transarterial embolization presented very severely with overwhelming heart failure under multiple rounds of transarterial embolization to now. And the heart failure was just not remitting, and this child was not going to survive. So as a last maneuver, we decided to directly embolize the prosencephalic varix itself. Finally, the heart failure abated, the pulmonary hypertension dissipated, and result completely intact. You can see in this case, the prosencephalic varix does not go away entirely like it did when we did transarterial embolization because there are coils, although you can see that they compacted significantly over time because there's essentially no more flow through them. So how could we plan for this? There are no animal models that even remotely approximate vein of Galen malformation at all. So we decided to build a phantom. We have a simulations group at the hospital that had previously built brain phantoms for ultrasound techniques. And we used cryogel, which has ultrasound visualization properties very similar to brain parenchyma. And we designed a phantom with a prosencephalic varix in the middle and a Falcine sinus that were taken straight out of the measurements of two patients we had. You can see two different shapes. We did a generation 2 of the phantom with a skull and a posterior fontanelle, actually, and we had to direct the needle through into the varix. And then we treated it exactly as the plan is for the fetuses. So we got a planning pre-embolization MRI. You can see, of course, the fluid in the varix is highly visible on the MRI scan in all the axes. And then we did the procedure under ultrasound. You can see the hands of the sonographer and the MFM, who actually are the part of the team that does the fetal cardiac interventions. And then we did the embolization, and you can see what it looks like under ultrasound. So you can see the needle entering the back of the Falcine sinus here, and you can see the microcatheter and microwire coming through. You can see the degree of resolution. You can actually see the the lumen in the middle of the microcatheter here, easily visible. Here's the wire coming into the varix. And then as we started to coil this, you can see the first coil being deployed with lots of acoustic shadowing. And then as we went on, you can see progressively more and more acoustic shadowing as the varix is filled. But even at the end, you can still see the coil being deployed here at the end. We then verified, I did a quick fluoroscopic view just to show myself that the coils were actually deployed right in the varix. This part will not be done on the patients, no fluoroscopy is involved. And we did a follow post-embolization MRI scan. And then we actually opened up the varix to show, opened up the phantom to show that the coil deposition was actually in place. So the goals of the study, the primary objective is to evaluate the safety of doing fetal embolization in this cohort of patients. Closely aligned secondary objective is to look at the efficacy. And again, the efficacy is defined as keeping those kids out of being in that neonatal severe cohort. So the goal is to get them to, they will be admitted to the NICU just as we do for all vein of Galen patients. They'll be observed carefully, but the goal is to have them discharged from the NICU without needing urgent embolization, without the overwhelming heart failure, and then bring them back electively for embolization if needed. There are clear safety endpoints, so there are unacceptable events that may occur within 7 days of embolization. Obviously, fetal death, fetal intracranial hemorrhage, other than minimal petechial hemorrhage, which we know can happen anyway in vein of Galen fetuses. Obviously, maternal death. The efficacy endpoints, as I mentioned, if we have to go to urgent neonatal embolization, that's a failure of efficacy. We'd expect almost all of the cohort to need urgent embolization. As mentioned, we're identifying this cohort based on the fetal MRI scan, based on that measurement of the Falcine sinus that I showed you, as overwhelmingly likely to need neonatal embolization without treatment. So the goal is to avoid that. If we need it, we have not succeeded. Death, we would expect a mortality rate of about 40% in this cohort based on the Great Ormond Street paper and the other literature I showed you. And of course, if brain MRI after birth reveals those kinds of parenchymal injuries that I showed you, that's a treatment failure. The goal is not only to avoid, of course, if the fetus is starting out with extensive parenchymal injuries, defined as over 10% of the supratentorial brain volume, we know that there's a significant risk of neural. So we're excluding those patients from treatment. If there's already fetal non-brain organ injury, so for example, hydropic fetuses with vein of Galen malformation have a near 100% mortality. If you start seeing pleural effusions, ascites fetally, that's a terrible prognostic sign. We may offer fetal embolization to those patients as a compassionate care intervention because we don't know whether that may help. But we know that with standard of care therapy, as a neonate, if you let those kids go on to be delivered and then treated in the NICU, they have a near 100% mortality. So this is an exclusion criterion for the trial. Fetuses, again, in whom that Falcine sinus or straight sinus measures less than 8 millimeters, that's our cutoff for inclusion, because they have a reasonable chance of not being in that severe cohort. So those are not the ones that we want to treat. Severe maternal obesity is an exclusion criterion based on our experience with the fetal cardiac interventions. It just becomes a question of whether it's possible to position the fetus appropriately in a mom who's obese. So that's an exclusion criterion. If there are other congenital anomalies, they're excluded. If there's preterm labor, rupture of membranes, anything related to the pregnancy, of course, if there's a maternal coagulopathy, if there's more than one fetus, any placental issues, and so those are the exclusion criteria. We are recruiting now. We have IRB approval at Brigham and Women's Hospital and Children's Hospital. These procedures are performed in an OB/OR at the Brigham, as the fetal cardiac procedures are. Our standard of care right now is we have pregnant moms with vein of Galen malformation come to Brigham and Women's for delivery. The baby is always admitted to the NICU. We put an umbilical artery and umbilical vein line in preparation for treatment if we need to treat them. And we get a neonatal MRI scan and a neonatal echocardiograph. We essentially watch them for a few days. The ones who will become sick will declare themselves certainly with don't show any of the signs the first few days, then we just end up watching them in the NICU for about 4 days, and then we discharge them. That will still continue even with this cohort. And here's the study team. And I think I spoke fast, so I've got through my slides faster than expected, but if you have any. Thanks for your attention.
Thank you very much, Darren. Darren, you probably covered this, but what's your ideal and range of ages of gestation that you're interested in doing this?
Yeah, that's a great question. So that's a completely open question about whether there is an ideal window for this. And because we don't know the answer a priori, we decided not to limit ourselves to any particular window. The limit is instead practical. So we know on embryological grounds that vein of Galen malformation forms early on in pregnancy. And the reason we know it is that the prosencephalic vein typically inciting process, the arteriovenous loops must form before week 11 when it ordinarily would have gone away. However, despite the fact that it forms early on, vein of Galen malformation is never seen on any prenatal study until about week 23. I think the earliest published case in the literature is week 22. It's almost certainly just a function of the size of the vasculature, and the size of the malformation is insufficient to be resolved by fetal ultrasound. So de facto, the earliest age would be around 23 weeks. At the other end of pregnancy, as you get very close to term, it becomes more and more difficult to position the fetus appropriately for treatment, and the risks actually go up of fetal positioning. So because we have a very experienced MFM team that has done this a lot with the cardiac procedures, it's going to be completely their discretion about how close to term we can still go in any individual case and still have a good chance of positioning the fetus. Of course, as you get very close to term, I'm not sure how much benefit there will be. Maybe there will be, but I don't know. You know, if you did this, for example, a day or just a few days before delivery, have you actually change the circulation enough to have a good effect in the neonatal stage? That I don't know. But for now, it's just practical limitations on both ends of the pregnancy.
Thank you. Thank you. We have other questions for Darren.
This is Beverly. Not a question, but a comment that this is a huge project, and it's groundbreaking. We desperately need something like this. A beautiful presentation, and I'm actively looking for patients in our area that we can take to Boston after they've been screened to have this procedure. So anybody that knows of a vein of Galen that's coming along, please contact me, and we'll get this patient seen and evaluated by Darren.
Thanks very much. Good to hear your voice.
Yeah, I'm having the dreadful experience of the second vaccine shot, so I'm doing this from home. But I'm so grateful to get the vaccine, so no complaints.
Yep.
All righty. Well, Darren, I think you've given us a lot to think about, and I'm glad, because I want the trainees to be thinking about the fact that the sooner we treat people, the better they will do. And prevention, this is a form of prevention. It's very early treatment is what it is. But prevention and early treatment are really the hallmarks of successful medical and surgical care. So this is wonderful. Thanks very much.
Thank you so much.
Okay.
Thanks.
Looking forward to seeing you in person when all of this is over with the COVID.
I would
Okay,
love to travel.
that would
Take
be
care.
great. Take
Okay,
care now.
bye-bye.
Thanks, everyone.